It's always great to be back in Montreal. I'm a Montrealer born and bred, and to have you organize this at the time of the playoffs and last night's victory by the Habs. Go Habs, go. It's great. And yes, I am from ISIS the Good. That's how we call ourselves these days. In fact, my assistant is East Indian. He's dark-skinned, and a couple of months ago he was crossing over into the U.S. By car, and when the border guard said, "Where do you work?" he said, "ISIS," and that was not a good idea. He was given quite a grilling. Luckily, he had a business card in his pocket, and he had a fairly nice border guard who didn't strip search him and just said, "Don't ever use that acronym again." So I think that the sort of sequencing here is great because we start off with Rex talking about the opportunity of linkage with electronic health records of genomics data. We had John talking about some of the linkages with health services data of a population-based cohort, and of course Ontario Health Studies, something that we are working with at ISIS in Ontario. So I'm going to give you a slightly different perspective, and I'm going to assume that a lot of you may not have a lot of experience of working with health services researchers and kind of give you the perspective that we have on this. Do I have a pointer? I do, okay. So what I want to talk about is discuss this notion of big data linkages from the health service research point of view. Give you some examples of the kind of research that we do routinely at ISIS. Discuss some novel, what we would call big data linkages that are underway or are soon to be underway, and also finish with what I see as some possible obstacles to these kinds of big data linkages that perhaps we can discuss. So just to give you a bit of background, we've been around in Ontario for about 23 years now. We're an independent, not-for-profit research institute, and we basically hold all of Ontario's routinely gathered health claim information. We have about 190 scientists spread across 5 physical locations in Ontario. So there's 2 in Toronto. One is our what we call the ISIS Central, which is on the campus of Sunnybrook Hospital in Toronto. And then we have satellite facilities, which are physical facilities that have full access to our data through secure linkages at the University of Western Ontario, at Queen's University, the University of Ottawa, and the University of Toronto. And we're building 2 more facilities, one in McMaster, and then one at that we're calling ISIS North, which is going to be based in Northern Ontario at Laurentian University and the Northern Ontario School of Medicine, which has a particular focus on Aboriginal health. So there's 2 things, I think, that distinguish ISIS. One, of course, is the data, and I mentioned the repository of administrative health data that we have, but that's supplemented with all sorts of other data. There are a variety of clinical registries that our researchers have accumulated through their own research grants. We have population-based health surveys that have been linked to the administrative data, care provider data sets, and over the last couple of years we've begun to link electronic medical records from primary care physicians in Ontario as well to our data sets. So that's the data part, but that's really, I think, the minority of what's important about what we have at ISIS. The most important thing are the people. So as I mentioned, we have about 190 scientists, about 150 analytics staff and data experts who've really become very well versed in how to use these data, how to create linkages that are very high reliability, and how to do all of this in a very secure fashion that respects all of the various privacy and security bells and whistles that we're all subject to these days. So our repository is big in scope and breadth. It's all individual levels, so we have data at the individual level. It's longitudinal. For most of our databases, we have data that goes back as far as 1991, and these are regularly updated. Some of the databases are updated every couple of months. Others are updated every year or so. It depends on the data set. And then the data sets that have been gathered under the auspices of particular research projects, they may be static and not updated depending on the grant. It's population-based, so it covers the entire population of Ontario, about 13 million people. And as was mentioned by John, as a universal, with a universal healthcare system, we have data on all hospitalizations, all emergency department visits, all physician claims, and so on. It covers the entire population, and I think that's one particular advantage to our healthcare system, and which enables us to do work that would be more difficult to do in some other jurisdictions. It covers a wide breadth of services, basically all of the publicly funded physician health services, and some outside health as well. there are definitely lacunes in our health data. So for example, if you were seen by a nurse practitioner in a nurse practitioner-run clinic and that nurse practitioner doesn't bill fee for service, we wouldn't have data on that encounter. It's a tiny fraction of health care, but nonetheless, there are areas where we have some challenges. Another example would be community-based mental health services, which are often delivered by non-physicians. And again, we have some challenge in gathering data in that area. All of our data is de-identified, so we link it through what we call the ISIS key number, which is a scrambled version of the OHIP number, or the Ontario Health number that every citizen in the province gets. And that allows us to link across all of our data sets across geography and over time. And of course, as I mentioned, these data are all linkable. So here's a key difference that I think we should spend a bit of time on, or at least I'll spend a bit of time on this morning, and that's that we don't have consent to gather this data, right? The individual citizens don't provide consent. They don't sign off in the way that's been described this morning in the preceding presentations to allow these data to be used for research purposes. So we gather this data under particular legislation that allows us to do so, to gather this information. But it does create barriers to how we can use this data, how we can share this data, how we can link it to some other data sets. And I think that's something that we need to consider as we start to bring kind of the two cultures, let's say, of basic science researchers who are focused on genomics with health service researchers and start to address problems together. So how do we have the authority to use and disclose or share the data that we have? Well, it's based on three pillars: legislative, privacy, and data governance. So the first is legislative. So in Ontario, one of the things that we were very fortunate to have was that when privacy, protection of health information legislation came in Ontario, ISIS already existed. So essentially, the legislation was written to allow ISIS to continue to do the kind of work that we've been doing. So we're named specifically in the legislation, the PHIPA is the acronym in Ontario for the protection of personal health information legislation, as a so-called prescribed entity. There are only about 5 prescribed entities in the province, and that allows us to receive identified personal health information without consent. We then strip those personal identifiers. We apply the scrambled IKN or the unique identifier that allows linkage, but the fact that we can receive identified personal health information is a huge advantage. The next level of sort of permission to use this kind of data is through very strong data sharing agreements that we have with all of our data partners, including the Ministry of Health. But we get data that comes from many other partners as well, and so we have data sharing partners with all of those partners that stipulate very specifically what we can and can't do with the data. And finally, we have very stringent policies and procedures within the Institute itself. And these are reviewed every 3 years by the Office of the Information and Privacy Commissioner in Ontario to ensure that it complies with the legislative framework. And I can tell you that that's not a routine kind of sign-off, yeah, your policies look good. It's an exhaustive review that takes about a year to complete, and we go through that every 3 years. So this is what the data looks like at the end. So if you imagine these columns basically represent sort of types of data that we have. These are virtually all at the population level. So we have, if we start in the middle column over here, we have what's called the RPDB, or the Registered Persons Database. This tells us about all of the individuals who are in the province, when they were born, when they die, and also we have data on cause of death through vital stats. We can link that data to all of the physician claims that those individuals may have been associated with, all of the inpatient admission records, all of the emergency department visits that they've undertaken, prescription drug claims. Ontario is one of those provinces that only pays for drug prescriptions if you're over 65 or on social assistance, so it is restricted to that, although we are talking to private pharmacies about trying to get that data as well, and a variety of other databases like home care claims and so on. We also recently have linked with the BORN database. The BORN database is a registry of all babies born in the province and linked to their mothers. And so that now is available for research as well. A variety of registries as well are linked, so a whole lot of cancer registries from Cancer Care Ontario are linked with our data. And we have new partnerships now, some with the federal government. So for example, the Federal Department of Citizenship and Immigration has shared with us all of the Ontario data, so we know about individuals who have immigrated to Ontario, where they come from, when they immigrated, and we can now follow their health status as they become citizens of Canada. We also have partnerships with a variety of Aboriginal groups in the province, the Métis Nation and First Nations through the Chiefs of Ontario, and this has allowed us to obtain copies of registries that identify who are Métis in Ontario and who are First Nation status Indians under the Indian Registry, Indian Act, the Federal Indian Act. And so we have received from the federal government, again, what's called the Indian Registry System, which identifies the status of Aboriginal populations and allows us to do work on Aboriginal health. So through these data sets, we've been able to create disease-specific or derived chronic condition cohort. So we have cohorts now of diabetic patients, hypertension, COPD, CHF, and others. And all of these, the algorithms used to identify those diagnoses have been validated through linkage with primary records. So typically physician office records or hospital records to validate that using a particular algorithm, we can identify a diabetic patient in our administrative data and that they truly are diabetic. And so we can use these to create cohorts and to study a variety of questions that relate to those individuals. So I'm going to give you a couple of examples of some of the work that we do. This is a study that I was involved in a couple of years ago, which basically asked the question, so I'm an emergency physician. I work actually clinically still in Toronto. And we were interested in the question of, okay, so if you walk into an emergency department and it's really, really busy and really crowded, are you more likely to be dead 7 days later than if you walked into the same emergency department at a time that was less crowded? And short answer is yes, there was an association, but I think the point I'm trying to make here is just to demonstrate how we did this study. We looked at about 5 years of data, about 14 million individual patient visits across the province of Ontario, and we linked 4 different Ontario Health Administrative data sets and StatsCan data to carry out the study. And I think it's just an example of when you can bring large numbers of visits together, the power that these databases can have. About a year ago, we underwent a strategic review, and one of the things that came out of that review was a new priority for the organization, which is to enhance the data that we have currently, and also enhance the access to that data. Because we heard again and again from our stakeholders that people wanted to have greater access to this data and wanted the opportunity to link their own data sets to ours. And I'm happy to say that we've made great strides in this direction. So you may have heard of the Strategy for Patient-Oriented Research, or SPORE, which is a CIHR-funded initiative. And this involves a series of bilateral agreements between the CIHR and provincial ministries of health. And in Ontario, the funding that we received under that strategy allowed us to create a platform that we call the Data and Analytics Services Platform. And this allows any researcher anywhere in Canada to have access to our data, to have a linked de-identified data set put up on our servers, and you can have access to that data. There's a fairly straightforward process of applying for that access, as long as you have REB approval and so on. You can then analyze these data sets to your heart's content. We're also now allowing for linkage of external data sets to our data sets, so bespoke linkages that a researcher may be interested in carrying out. Again, this is all as a result of this initiative, and I think it's an exciting time for this area. So just again, some examples of recent novel data linkages that we've undertaken. I mentioned that we had received data from the Federal Immigration and Citizenship Department in Ottawa that identified immigrants to Ontario and where they came from. This is just showing you the prevalence of schizophrenia among immigrants versus the non-immigrant population, showing a substantially higher rate among refugees compared to immigrants and compared to the non-immigrant population. And I think you can immediately see the policy relevance of this kind of research and suggesting that particular attention needs to be paid to mental health as part of immigration programs. Similarly, a study of ethnic background showing differences in Chinese and non-Chinese patients who are hospitalized with heart failure, differences in the kind of treatment they get, differences in outcomes that they receive as well. Again, I think important clinical and policy relevance, and all resulting from this interesting linkage of a federal government's immigration data with health administrative data. Through the linkage with the Métis, again, a large Aboriginal group across Canada, but in Ontario there are about, I believe it's about 40,000 Métis across the province of Ontario. We were able to study a variety of chronic diseases and their prevalence, and demonstrate much higher prevalences for basically every disease that we looked at among the Métis Nation. Again, major policy and clinical relevance. This study linked social service data sets, so individuals who are on disability or social assistance, with our health administrative data sets, and looked at whether they received cancer screening tests equivalent to the rest of the population. And in fact, we found that they didn't. And this has been replicated in a number of other screening studies, showing that individuals with disabilities typically are not receiving the same kind of cancer screening services that the general population undergoes. Again, I think the study speaks for itself in terms of its importance. Here's another example. This one is just getting started, but this methods paper was published a little while ago, and this is being led by Jack Tu. Jack is a cardiovascular researcher that you may know of. He heads our cardiac research program at ISIS, and this is called the CAN Heart Study. And this, I think, is a really interesting example of a kind of novel big data linkages. And what they're doing, this is just a graphic from his paper that I'm happy to provide you a link to if you like. But they're linking 17 different databases together. And what's different here, I mean, we link lots of databases together all the time, but what's different here is some of them are population-based, some of them aren't, some of them are surveys that only include a few thousand people, some of them are from electronic medical records that cover a couple 100,000 people. So the point is, depending on the question you're asking and the kind of data you want to use, you might have a sample size that could vary from a few thousand patients to a few million patients. But by having these data all together in a sort of bespoke fashion, it allows for a number of very novel research studies to be undertaken. And so this is just another example of the kind of work that we're doing currently. We've begun over the last couple of years to link our administrative data with EMR data, electronic medical record data from primary care physicians in Ontario. And currently we have about 800,000 patient EMRs that are linked to our data. So these are physicians who've consented to allow linkage of their data to our data. Consent is required of the health information custodian. That's the term used for whoever owns a medical record. In this case, it's a primary care record, so it's the family physician. And so consent is required from the physician, but not the patient. This is not a population-based sample. These are obviously physicians who've self-selected, and there are some limitations currently in terms of which kind of EMRs we can link, but those are rapidly being overcome as technology improves. And we're very interested in expanding this substantially to hopefully have a population-based linkage of electronic medical records with administrative health records. And it's important to note that we're able this way to follow patients no matter which hospital system they're in, whether they're in Toronto or they're moved to Ottawa or they go up north or they move to Windsor, or whether they're not moving but just being admitted to different hospitals. This will allow us to follow them across the entire system, including their electronic medical record system. The Ontario Lab Information System, we've just completed data sharing agreements to link that data. This contains about 80% of all lab test results that are carried out across the province. So we'll be able to, again, link lab test results for most of the population of Ontario, actually for the entire population, but just most of the lab tests. As I say, about 80% of the lab tests are contained within it. This includes hospital-based labs, it includes private labs, and it it will also include public health laboratories as well. This is a particularly interesting linkage that we are undertaking with the Ontario Brain Institute. The Ontario Brain Institute is looking at a variety of neurological conditions and trying to bring together researchers that traditionally have not worked together. In fact, folks like you and like me. These are neuroscientists with particular interest in the diseases you see in the purple columns: CP, epilepsy, neurodegenerative diseases, depression, dementia, and so on. And depending on the study, depending on the researcher, there may be neuroimaging data, clinical data, genomics data, proteomics, metabolomics, and so on. And we are working together to create a data safe haven where these data could be linked with our data to allow for the kinds of projects that we've been, studies that we've been talking about this morning. And this, I think, is a very interesting project that we've been working on for now a couple of years. And finally, I'll just mention that I said at the outset that we receive data from the Ontario Ministry of Health, all those sort of routine health administrative data, but we're now in discussion with multiple ministries in the government, Ministry of Education, Ministry of Community and Social Services, Ministry of Justice, even Finance Ministry, to try to develop the opportunity to link data from across all of those ministries for a much more holistic understanding of how policy and services can influence a variety of outcomes, health, of course, being the thing that we're particularly interested in. The argument, of course, that we're making is that if you look at education data in a silo, or health data in a silo, or social service data in a silo, you get siloed policy. But if you look at it all together, of course, you get to the nirvana of where you have public policy being developed and implemented in the light of data from across the entire government. And the reason why I like this graphic in particular is because, not that I mean, it's a pretty nice graphic, but the main reason is because it was actually developed and we borrowed it from the Ministry of Health. And this is an argument that ministries within the government are themselves making. They recognize the need for this. And here's one terrific small example. There was a linkage of correctional services data, so prison data, with health data that showed that about something like 40% of the incarcerated population in Ontario had had a traumatic brain injury. So 40% of people who are in jail in Ontario have had a traumatic brain injury. And you kind of wonder, had traumatic brain injuries perhaps been treated a little better, might we have avoided incarcerating some of these individuals, which ultimately is way more expensive than healthcare. So again, interesting examples of how by linking data across these multiple silos, certainly new discoveries can be made, and there's the opportunity for better health policy. So I'm going to finish with a couple of the obstacles as I see them, and I'm interested in hearing your thoughts. So at least one of the obstacles is that, we come from different cultures. So if you're a geneticist, and you've been studying, doing GWAS studies your entire career, you may not really understand the kind of language that I speak as a health services researcher, and vice versa. And so we need to understand each other and understand the constraints and the things that we can do well in terms of health services research, and the things that you can do well in genomics or all the other omics, in order to identify what are the best studies that we can do together. And I think Rex gave some great examples of how this can be done. But I don't think this is a trivial task, and I think it's something that we should be talking about up front. Data governance and the need to balance access to data with privacy and security. I've heard a lot of, in my role at ISIS, I hear a lot of frustration from people about, these silly rules and about privacy and access and so on, and let's just get everything up in a cloud. It isn't that simple. It just isn't. And consent is one of the issues. Certainly the types of data, when someone has signed off on consent to use data forever for any purpose, very different from non-consented data. And this is simply a reality that we face, and something that we have to tackle together. There are solutions. There are ways of doing these linkages and providing data access that respect the security and privacy and legal constraints, but I think we can't forget them. What's the question? We're sort of operating, I think, in a little bit of a field of dreams scenario where we say, let's build this fantastic infrastructure for data linkage, whether it's population-based cohorts or genomics, large biobanks, and link it all with health services research, and then all the magic's going to happen. And that may be true. And I believe that this is the future and that we need to all be part of this. But sometimes I worry that we aren't very clear on what the questions are that we can answer with this kind of work. And that the true value of these kinds of linkages, we're having some trouble demonstrating them to the kinds of people that are going to be funding them. So I think that's really important, that we think carefully about what the questions are that we can be answering and begin to demonstrate more clearly the value of these linkages. I really believe that we need to keep track and be having a conversation with the public on an ongoing basis. There is no question that the public acceptance of these large big data linkages, especially on health information, is both conditional and fragile. And this guy here, you know, Edward Snowden, and you know what that, the NSA breaches and how that has kind of sent a chill down people's spines. This woman up here, I'm sure you don't know. Her name is Lois Kamenetz, and this is a woman who about 2 years ago was traveling from Pearson Airport in Toronto down to Miami to go on a cruise. And she went to the U.S. Customs Guard at Pearson, and the guy scanned her passport and said, "Oh, no, I'm not letting you into the country. I consider you pose a risk to the safety of the U.S. And she was like, "What? I mean, you know, doesn't look that dangerous, does she?" And what had happened was that he considered her a risk because she had a history of mental illness. And it turned out that in the border records, up came a record that demonstrated that she had been suicidal 2 years before, and had been hospitalized for this. And so, based on that, the border guard barred entry. Now, putting aside the issue of the judgment of the border guard as to whether she represents a risk or not, how the hell did a border guard know that this woman had been suicidal 2 years before? I can tell you, when this story broke, and I read it in the paper the next day, before this sort of full explanation came out, a chill went down my spine thinking, has someone hacked into our databases and pulled out, you know, hospitalizations for mental health reasons and linked that somehow? No, what happened actually was that the police in Ontario, in Canada, share all of data around 911 calls with the US as part of security arrangements. And at the time that she was suicidal, her husband had made a 911 call. And that brought the police, who then brought her to hospital. She was treated, she got better, she was no longer suicidal, and everything was fine. But the 911 call remains on her record. And these are the kinds of instances where people say, no, I don't want my data linked. I don't want people to know about my health records. I don't want people to know about what's in my family doctor's record about my mental health or my sexual health or when I had a back injury or something like that. We need to keep talking to the public, telling them what we do, demonstrate the value in order to not lose faith. And I'll just mention up here, care.data. If you have time, take a look at the care.data debacle. This was over the last couple of years in the NHS when there was a big push to link electronic medical records with administrative data, make them available for research, for industry, for all sorts of great things. And when, through a variety of reasons, and I think the NHS actually handled this very badly, but for a variety of reasons, there was a huge backlash. Publicly, the whole thing was shut down, and several years were lost in terms of the ability to link these kinds of data. Finally, you can make really dumb use of data, and I think we need to be aware of this as well. This story you may remember from the Toronto Star about a couple of months ago, where a couple of intrepid investigative reporters had taken a publicly available adverse event database for vaccines that's managed in Canada, and basically pulled out a whole lot of strange and unusual events that occurred post-vaccination. In this case, it was for HPV vaccine, and made a claim that HPV vaccine was dangerous and was leading to deaths and all sorts of terrible diseases among young girls getting the vaccine. It turned out the whole thing was obviously a silly analysis, and it ignores, you know, tens of thousands of patients in cohort studies that demonstrates the value. But I thought this was an interesting series of tweets. Those of you who know Ben Goldacre, he got dragged into the debate around this story. Ben is a highly esteemed science writer out of the UK, writes for The Guardian. And I'll just read these out here. He says, "This is appalling, ignorant, irresponsible journalism. Reporting the raw data from an open adverse event reporting system in that manner is simply misleading and an abuse. Where data is made openly accessible, we all have a responsibility to reciprocate and analyze, report on it competently. You have abused that trust with a platform so large that you will inflict harm." And I don't think it's a stretch when we're dealing with measles outbreaks across North America as a result of concerns around the safety of vaccines, that these kinds of uses of data can actually be harmful to the public and to health policy. And I'll just close with this last question as a potential obstacle. We may be able to come up with great questions. The question I would have, or the potential obstacle, is anyone there to listen to the answer that we come up with? And our institute, what we tend to focus a lot on is the ability to influence health policy. And I think if we don't include policymakers and decision makers in the process early on, to be sure that the questions that we're asking are policy relevant, we may find that we're carrying out great studies, coming up with great answers, but that we don't have an audience to listen. So I'll stop there. Thank you very much for your attention, and I'm happy to take any questions.
Are there any questions?
Thank you very much. Brent Richards, McGill University. So I'm sure you've given thought to the collection of biologic samples. I'm wondering if you can comment, well, even if that's possible for ICIS, that is something that ICIS should be engaged in, and if so, how can that be done?
Yeah, so we've not ourselves collected biological samples, and where the linkages are happening are through the Ontario Health Study. So we're in conversation with Mark Perdue and Tom of the OICR around those linkages. And we're very excited about the opportunity to link to the biological specimens in the OHS. As well, we have, as I mentioned, the Ontario Lab Information System, so we have a whole variety of lab results, but it wouldn't be, for example, genomic data and so on. I think, so we're a health services research institute, and we're health services researchers. I think where we see the opportunity there is to be partnering with scientists who are studying genomics or studying metabolomics or studying proteomics, and to have them bring to us cohorts that they may have, or samples that they may have collected for potential linkages. One great example that we've been talking about recently is every newborn in Ontario gets, and I think across the country, gets a blood spot, done a dried blood spot for congenital disease screening, and they're kept for about 20 years. Remarkable opportunity to actually analyze those blood spots for the entire population of newborns and then follow their health over time through our databases as one example. I would say that's something that we would see doing through partnerships as opposed to ICIS leading that work itself.
Great. One more question. I know some of the other talks are going to talk methods development, and we have a lot of experts in the room, but analyzing these large data sets must pose some challenges which are technical or analytical, and I wonder how much of your institute actually works on methods as opposed to just crossing data, comparing data.
Well, I think that's where we talked about data and people, right? I think that's where the people come in. So we have about 5 statisticians and methodologists whose entire current careers are sort of based at ICIS, and they have developed a lot of very innovative and novel methods to address some of the challenges. The challenges multiply when you start talking about genomic data and the computational challenges and so on. Again, that's where partnering with computer scientists, with the geneticists and so on, and statisticians are going to be key. I have no doubt that creating this kind of platform is going to lead to all sorts of new methods and techniques in those areas as well.
I think we're going to thank all the speakers. Session.